much. And this last presentation really is about bringing out points for discussion based on everything that you've heard today. It's not moving. No. Yeah, now. Yeah. So you've heard about all the landmark studies, and we've had some studies in India also, may not be RCTs and may not be multicentric, but basically, not moving. Not moving. Yeah. So both are effective in reducing IOP and AGM. Please remember that. Non-valved ones are able to achieve lower IOP with fewer medications, but they have slightly increased incidence of hypotony. And this is something you need to be aware of. Overall, failure rate is also lower with non-valved. So the key points really are, which tube is better? Again, you know, is there any one superior over the other? You have to choose based on the knowledge you have with regard to all these tubes. Even though non-valved have complete success rates better across all studies. Which tube is cheaper is a consideration we have to keep here in India. And of course, the Orolab aqueous drainage implant, or the ADI, is very cost effective for us. It's indigenously developed and it has been designed on the bar weld. Bar weld is not available in India. And which tube reduces IOP more with lesser number? You know it's the non-valved. ACP, the Ahmed Clearpath, is the newer non-valve which only recently got introduced in India. We don't have so much data coming out of India, but from what I picked up, they are comparable to the bar weld. The advantage, there's a very significant advantage, that you need to only open up a small part of the conjunctiva. The plate size is smaller, so you can place it between muscles. These tend to have massive advantages where the conjunctiva is extremely sick. And of course, I showed you this photograph. You tend to get very diffuse blebs when you compare it to valve tubes. So which one to choose? Basically, if you want an immediate reduction in IOP, it's a no-brainer. You need the valved one. And, you know, you need to look at safety aspects in advanced glaucomas, one-eyed patients, and at the end of the day, it depends on patient and surgeon's comfort level of which tube you're going to choose in which patient. So we're coming back to the same thought process, that you customize your treatment based on the patient who is in front of you. Thank you very much. So I'd like just to kick off the discussion, unless there are some questions from the audience, what is your practice in silicon oil? What do you do? Inferior tubes?
No, I still do a superior tube. I'll put a superior tube.
Okay.
With the oil removed, of course.
Yeah, but then, you know, you still have the emulsion hanging on in the eye, and it then tends to block the tube.
Yeah, we don't put a inferior.
Superior tube. I don't do it inferior, at least for the first time. And we do find the emulsified oil, and as the patient is on the table lying flat, like the one video I showed initially, that was actually AGV SOR removed silicon oil, emulsified. You go in and wash. Of course, you keep washing, it's going to keep coming again and again and again. But again, wash as much as possible.
Exactly,
and
exactly.
Superior.
Same with you guys?
Yeah, silicone oil, if it is there, a recent silicone oil, not an emulsified one, I would ask the VR surgeon to first remove the silicone oil. And at a second stage, do a tube implantation if the IOP is still not under control. In emulsified oil, I think if it is very significant, again, not removed, then complete removal of the silicone oil. If only a bit of it is there, I think, with the wash.
You know what, Amit? If glaucoma has occurred, and it's not within 1 month, it's 3 months later.
Yeah.
Is the oil.
Yeah, I know, and I explained the
so,
patient
beforehand.
removal
of the oil actually doesn't make any difference.
But I explained to the patient that you will require a glaucoma surgery, but we'll do it in a staged manner, because I had a choroidal hemorrhage in a SOR with tube implantation done together.
Not to do the same.
Anything
time.
else, Jayant, you want to add?
Yes,
or?
had little experience with silicone oil tube, but tubes do work, but I find the oil keeps coming back, the globules, small ones, coming even after all the removal. So I just go in the anterior chamber and keep removing SOS, not always too frequently because endothelium can go. But just remove them because they tend to,
So
and I
wash
also
out
do.
SOS.
SOS wash out, and it's not that difficult to wash them
Someone
out.
else? Yes, please.
I'm not a glaucoma specialist, I'm a retinal surgeon. Just wanted to ask you, what would you do if the oil cannot be removed? There are eyes where you cannot remove the oil because we know recurrence can occur, but this glaucoma has to be still managed. What would you do?
No, I do tend to do quite a few tubes with the oil in situ. My take on silicone oil is I do go superior, I don't go inferior. Inferior, I've burnt my fingers. I find that oil tracks subconjunctivally and then you get subconjunctival silicone oil particles. So what I do and what has worked now is I make intraocular fenestrations. So the particles go and stick to the fenestrations and the tip of the tube is still free. Yes, it doesn't get blocked. So this has worked quite well. Even when silicone oil, recurrent RDs and silicone oil has been placed again and again, it works. It has worked.
I have an alternative suggestion. I'm wondering instead of... can you hear me? Sorry, I have an alternative suggestion. I think this is obviously, thankfully, not that common a problem, but when it happens, it's quite irritating, and when you end up doing very invasive procedures, it could lead to problems, as we are seeing. Sometimes using a micropulse diode or even a diode laser, a limited diode,
We do that too, sir.
has worked beautifully in these cases.
We do a limited diode.
A limited
for those
diode.
patients.
I think that solves the problem for many of my patients. Not that many.
The one suggestion I have is that if a VR surgery also has to be done at the same time, you can ask your VR surgeon to do a endo CPC rather than doing a transcleral, which makes it much more easier.
Absolutely.
Okay, and if it's a pseudophakic eye, then of course you can do your routine tube implant. But I don't see any objection to putting a tube inferionasally if there is a aphakic eye where you're always concerned about the oil trying to migrate through the tube. Is there quite an objection to putting the tube inferionasally?
What happens is that the oil tracks down the tube and then presents itself subconjunctivally. That has happened pretty often.
Slight
where,
increasing chance of endophthalmitis also with inferior tubes.
Yes and no.
And where ECP is concerned, probably I'm the only one doing, as a glaucoma specialist, doing ECP in the country. And I have looked at my figures. Actually, silicone oil glaucoma is the worst prognosis where ECP is concerned. So, I'm trying to move away. I do offer it because it's a MIGS at the end of the day. It is very small incision, very quick surgery. So I do offer it as the first stage, but I find quite a few of them actually end up either getting a tube or I'm doing a transcleral diode for these patients also.
To answer Prof. Gopal, anecdotally, I've done inferior tubes for some silicone oil patients, and they have worked well because some other surgeon. So I've seen a flip side, so I can see both ways. I see your point. I totally get it as well. But where they did a superior and got blocked, so I did inferior nasal and it worked well. But it's N of 2, N of 3. My numbers
I think
are very
by choice,
low for this.
we probably would not. None of us would probably do by choice the first tube as inferior. The second tube would probably consider inferior, infranasal.
Or a second procedure. In fact, if you do a diode and then it doesn't work, then you do inferior nasal tube.
Is there any other point? Yes, please. Please use the mic. As you would manage any decompensation, if the tube is in correct position, it's not anterior, it's not touching the endothelium, If that is the case, then you have to reposition. There is no doubt about this. But if the tube is in good position, then you start by giving some, topical
Hypersolid.
steroids. You may even give oral steroids. You can give hypertonic saline. You can take these measures first.
Also,
Before.
sometimes it's the disease, like in eye syndrome, it's the disease that is progressing because it's both glaucoma as well as the corneal disease. So if that is the case, again, you treat it conservatively initially. If not, then yeah, you need to do something about it either.
Yeah, I think
Actually, this patient is around 45 years old, keratoconus bilateral PKP, and she developed cataract in one eye. I did phaco and AGV, 1.0 CDR. So both eyes, 1.0 advanced glaucoma.
Is the tube long?
No, this first
Adequate.
one was okay. There is no problem. The second one, it was already pseudophakic and had a graft. So she is maximum medical therapy. She doesn't want to use drops. So she requested me to put an AGV in the other eye. So I put AGV in this eye. Tube is in very good position, not touching.
So it's
the eye,
probably
is
the
not
rejection that is happening. So you need to
See-
treat it accordingly, like a rejection only.
Yeah, and it
But if
started
you had to,
developing-
I think if you need to do a second PKP later on, then you might trim the tube or put it in the sulcus.
But I would like to make
the
another
anyway
point
to
here. If a
prevent
patient,
it getting
patient
further
does
damage.
not want medication after surgery, AGV is not a good choice.
That's true.
Yeah. You have to, if you're giving 4 or 5 medications after AGV, you find you're still doing 2 or 3.
Yeah.
So it's not a good choice.
And
If you
can-
really want to get rid of medication, you have to start thinking in terms of non-valve surgery.
The tube, the localized decomposition should start near the tube entry.
Correct. If tube is
That's
the
where it starts. If it is
reason.
any other area, then it could be related to the
Actually,
general
it's the
condition.
graft which is getting decompensated.
Then
Yeah.
it's not
So it's
then
not
it's
because
not
of the
a problem,
tube.
yeah.
not the tube.
Tube, yeah. But if you're going to do a regraft or if you're going to do some procedure, redirect the tube into the sulcus.
Exactly.
That will solve
You
your
have
problem
to,
the next
yeah,
time.
You have to.
Because the next graft survival is going to be 60%, 65% of the first one. You're not going to get as good a survival rate as the first
We
one.
do that quite often actually. Most of the time these kind of decompensated corneas due to corneal problem primarily. So what we do is we do a desec or now we do the SPEDEC procedures in which I redirect the tube into the under the iris.
Yes.
And the iris
At
and
the
then
same
do
time,
this.
at the same
Sulcus.
time.
Yeah.
Do both
So
at the same time.
actually, it's a good idea to put it in the sulcus in the first
first
place. If the
place, true.
patient is pseudophakic
Yeah.
or aphakic, there is no reason. Sometimes it's difficult. I've had problems with the pseudophakia being done elsewhere, and you don't know, whether there were complications during surgery. And when I am doing the surgery, I'm seeing zonular dehiscence and vitreous coming. That's a different matter. But generally speaking, I would say put it in the sulcus.
So is that the message that if you have space and it's pseudophakic, would you put it in the sulcus
Yes.
generally
Always.
also?
Yes.
Yeah.
Yes.
So I think that
Yes.
message is if you can
Yeah.
just
Yes.
clear once.
Putting it into the sulcus, is it easy, madam?
It is
No.
not difficult. You have to bump up the sulcus, and you have to go 3 millimeters behind the limbus to enter.
3 millimeters.
Yes.
Thank you.
Okay,
so much.
I think we've taken up enough time. I do thank all my co-instructors. It started off as an empty hall, but we are glad we had some audience and some questions. Thank you very much.